Thank you all for coming. Good afternoon and good morning in Chicago, a city I know is not known for its farm animals. But you know, I was going to put up a picture of Sol Steinberg's The View from Ninth Avenue of the United States. You know how we New Yorkers are. Anyway, I'll start by as Carrie said, I worked on the DSM-5 that came out in 2013. I actually also worked on the World Health Organization's ICD-11, which came out in 2019. And we're now revising the DSM-5, and I'm the section editor of the chapter on gender dysphoria. And I'll start, by talking about how the idea that, for most people, gender is binary. These are the universal symbols of male and female. And you can go to a restroom in any airport in any country, regardless of whether you speak the language, and pretty much you'll find the restroom that suits your purposes. But in Scotland, sometimes the binaries are inadequate because, some people don't know which restrooms to use in Scotland. So gender is complex. I mean, this is a subject, I've worked in this area starting in the DSM-5 for more than a decade now, and I always feel like there's a big picture that I can't see, and I haven't read anybody describing the big picture, and so the closest I can come to the big picture about this issue is the 6 blindfolded scientists trying to describe an elephant, that there are lots of moving parts, and we're going to review some of those moving parts today. So start with a controversy that was about a year and a half ago. This was a 7-year-old boy's parents were divorced. One of the children started identifying as a girl and the mom wanted to socially transition. The parents had joint custody. The father did not want social transition. And so they went to court. And I'll talk about that at the end. I'm just going to define, this is the table of contents. I'm going to define some terms, talk about some controversies, talk about some treatment approaches. And then at the end, I'll give you some news from the popular media. So sex is what we think about as being the biological attributes of being male or female, usually understood in terms of reproductive capacity, sex chromosomes, gonads, sex hormones, and non-ambiguous internal and external genitalia. While gender is the public and usually legally recognized lived role as boy or girl, man or woman, with biological factors seen as contributing in interaction with social and psychological factors to gender development. A sexual orientation is a person's erotic response tendency to be directed to individuals of the same sex, which we call homosexual, or the other sex, which we call heterosexual, or both sexes, bisexual. And historically, sexual orientation and gender identity have been confused with each other, but they're not the same thing. As we know, I think really started entering the mainstream literature in the middle of the 20th century. When working with transgender people, it's not clear whether to call, to describe their sexual orientation either pre or post transition. So the literature has the term androphilic, meaning attracted to men, regardless of their gender identity, and gynophilic is attracted to women. And it's really important to keep in mind that gender identity and sexual orientation are independent variables. A sexual identity, for example, is one's subjective experience of one's sexual desires or attractions. How I think and feel about my sexual attractions, which is my sexual identity, is not the same thing necessarily as my sexual orientation to whom I'm attracted. A gender identity is an individual's identification as male, female, or some other category than male or female. And again, whether I think of myself as male and female tells you nothing about whether I'm attracted to men or women. Transgender is a popular word that for people whose gender identity or expression or behavior does not conform to that typically associated with the sex to which they were assigned at birth. And there are a lot of other terms, for the other gender identities that we're hearing nowadays, gender fluid, gender nonconforming, etc. If you can't keep up, don't worry. Nobody can keep up because these are all very, in some ways, although many people may use the same terms, they may not use them in the same way. And so it's not always clear what people mean, but these kinds of differences do exist. A gender is expression, is how an individual demonstrates their gender to others by the way they dress, behave, and their appearance. And it's a term that's increasingly used in non-discrimination documents. Historically, we talked about biological men and biological female. This assumed that the biology of gender resided in the genitals. So if you were born with a penis, you were assigned male. we now know that not everybody's assignment takes. So we talk about birth assigned males or females, or individuals assigned male, female at birth. There was a term, it still is out there, which we use in DSM-5 called natal female or males. Apparently now it is no longer acceptable. This is an ongoing issue within this community where language is changing all the time, and it's really difficult to keep up. So don't feel bad if you can't keep up, because I don't always keep up. And gender dysphoria historically is the distress that can accompany the incongruence between an experienced or expressed gender and one's assigned gender. And it's the term that we decided to give in the diagnosis in DSM-5 that replaced something that used to be called gender identity disorder, and in the ICD used to be called transsexualism. In the ICD, we changed the name to gender incongruence because it used to be called transsexualism in adolescents and adults and gender identity disorder of childhood. And we didn't use the word dysphoria because the ICD took the diagnosis of gender incongruence and took it out of the mental disorder section of the DSM. And I'll talk a little bit more about that later. So gender reassignment or gender confirmation is an official, sometimes legal change of gender. It might simply involve a social transition, which basically means the way one dresses, cut one's hair, whether or not people wear makeup, etc. Hormone treatment is use of feminizing hormones in someone assigned male at birth, or masculinizing hormones in someone assigned female at birth. And gender confirmation surgery, which historically was called sex reassignment surgery, are the procedures by which a person might change their physical appearance to look that of the other sex. It has many other names in the community, and it's really important to keep in mind that surgery is rarely performed on anybody below the age of 18, unless they have what we call a disorder of sexual development or an intersex. I'll talk about that in a minute. Transsexual is the historic medical term for someone who needs hormones and/or surgery to modify their body. These can be partial or complete transitions. It's important to keep in mind, one, that not everybody wants a complete transition. Some people just want hormones and not surgery. Some people want surgery and not hormones. Some people don't want either, and some people can afford neither. So there's a wide range of reasons why you see diversity. Historically, the literature referred to male to female or MTF transsexuals. The community calls such a person a trans woman. Female to male is FTM or trans man. And keeping in mind that gender identity and sexual orientation are independent variables. This is a very famous trans woman who publicly transitioned, Caitlyn Jenner, who transitioned from male to female and is publicly gynephilic. She was married to a woman before she transitioned, and she still admits being attracted to women since transition. Chaz Bono is a trans man, publicly transitioned, first came out as a lesbian and then transitioned to trans man. The child of Sonny and Cher, for those who don't know, and also publicly gynephilic, attracted to women. Cisgender is a term used in the transgender community to describe people whose gender identities align with their assigned sex at birth. So if you are listening to me now and you're not transgender, you're probably cisgender, although you might have some alternative gender identity. But it's like the homosexuality, for example, came out in the scientific literature, entered the popular imagination, and people in the 19th century didn't call themselves heterosexuals, they called themselves normal. But today everybody knows about sexual orientations, and the same thing is happening now with the transgender cisgender dichotomy, because newspapers are increasingly using the term cisgender. And it comes from the Latin meaning on the same side, but I won't show you that. The next slide. So transphobia is patterned on the word homophobia, which emerged in the 1970s, and includes a wide range of negative attitudes, feelings, or actions towards transgender people. And it's also seen as underlying the social stigma confronted by transgender individuals, as in bathroom bills, which I'll discuss. And it is undoubtedly a cause of fatal violence that disproportionately affects transgender women of color. There's some other terms. Misgendering is the use of the wrong gender of the person's gender expression. So if a trans woman is referred to as he, or trans man is referred to as she, that would be an example of misgendering. Dead naming, a term from the trans community itself, is using the person's pre-transition name. which they're not using anymore. And sometimes that can be accidental, and sometimes that's deliberate, because sometimes people get confused, and that happens all the time. But sometimes people deliberately refuse to accept the transition, and so they misgender and dead name people. Pronouns. Facebook offers more than 50 gender options for pronouns. I have no intention of memorizing all 50 options myself. So you can always ask, what are your pronouns? Not necessarily what are your preferred pronouns, which is how the language how people used to talk about it. Now, gender policing is the imposition or enforcement of normative gender expressions on others. So I think we all have done a little bit of gender policing in our lives. For example, if you're walking out of the men's room and you see a woman confused walking into the men's room, you might tell her she is walking into the wrong restroom, because that's how we police gender among other people. Gatekeeping is a term that comes from the trans community that refers to the practice in the historical past of determining whether or not people should be allowed to transition. That is, the idea that the role of mental health professionals was to weed out the so-called true transsexual from other people. Countertransference, this is for a more mental health audience, it's just the personal reactions of the therapists who may do gender policing in their own therapy sessions. Now, gender beliefs are implicit cultural ideas about essential qualities of men and women. It usually allows only for the existence of two sexes. And gender beliefs are expressed in everyday language that assign binary gendered meanings to what individuals do, think, and feel. And some common examples are, people might feel the need to say, female doctor, because we presume often, not so much anymore as once, but that the doctor is always a man. But almost always people qualified that their nurse is a male if that's the case, because we think of nursing as a feminized profession. And gender binaries are maintained by insisting that every individual who's assigned to the category of man and woman at birth, that you conform to the category to which you've been assigned thereafter. And the categories of man and woman or boy and girl are considered mutually exclusive. So what are some of the controversies that we're seeing? And we'll talk about some of them briefly and some in more detail. So military service. In the Obama administration, it was determined that they fund studies, because other countries allow transgender people to serve in their militaries, that there was no downside to allowing trans people to serve and also to transition while they were in service as well. This was stopped during the Trump administration and now reinstated in the Biden administration. So this is one accommodation. And if we have a Republican president in 2024, it may change again. School locker rooms is a big issue for some people. Again, the Obama administration it issued guidelines that saying that people should be able to use in high schools and schools the locker room that fit their experienced gender or their expressed gender. But this was reversed in the Trump administration. I think it's been reversed already in the Biden administration. This is an interesting question, because most trans people in locker rooms and in bathrooms, which I'll talk about, don't really wish to exhibit themselves. Many people find a way to change privately and not do anything. So it's sort of a fake issue. Sports teams, this is Republican states are now passing laws that say that trans girls, for example, cannot compete in girls' sports in high school. And we could talk about that if people want. And then there are bathroom bills, which started in North Carolina, where they said that people could not use the bathroom of their express gender, but they would have to use the bathrooms of their birth-assigned gender. North Carolina backed down from this when many companies boycotted the state to do their business there. But this is always in the background. And this is, for example, this is what a bathroom bill means. It means that Caitlyn Jenner has to use the men's room and that Chaz Bono has to use the ladies' room. So that, so we can talk about why people are trying to do these things, why. There's another controversy, that more of an academic controversy, called rapid onset gender dysphoria. Lisa Littman, a psychiatrist up at Brown, published a study of adolescents and young adults who are showing signs of what she called a rapid onset of gender dysphoria. She interviewed 256 parents who said their kids were suddenly showing gender dysphoria symptoms and identifying as transgender at the same time as this was happening in other kids in their peer group. And the parents felt this was due to a process of immersion in social media, which preceded their child becoming gender dysphoric. She defined ROGD as a development of gender dysphoria that began in adolescents or young adults who would not have met criteria for gender dysphoria in childhood. And she raised the question of, was this an issue of social contagion, similar to what we see in eating disorders, where groups of girls usually, if one of them develops anorexia, the others may develop it as well. And she said it was unlike cases of gender dysphoria in the research literature. To be clear, though, what is different is what the parents reporting so-called rapid onset, because the literature really, we have a child diagnosis and we have an adolescent and adult diagnosis. And many people who have the adolescent and adult diagnosis historically never met the criteria for gender dysphoria in childhood. That is actually not new. So when the study was published, there was immediate criticism. 2 weeks after it came out, the journal announced a post-publication review, and Brown University, which had put up a notice about it in its website, retracted its press release promoting the study, removed it from the website. It was seen as a political attack. One transgender activist called it a poisonous lie used to discredit trans people. And then there were, academic criticism saying that, what we call methodological criticism. Parents were surveyed rather than young people themselves or their healthcare providers. And so the article was revised in 2019 with really minor methodological criticism. It did not really alter the substance of what the report was. So prepubescent children are among the other controversies that go on. So in the literature, there are now 11, actually one just came out this year, 12 published peer-reviewed studies of what was called gender identity disorder childhood between 1972 and 2013. And the studies, and these are small studies because these are all studies that were done at gender clinics, which don't have large populations, but the majority of the children that were assessed grew out of it. That is, they didn't grow up to be trans, they grew up to be gay and were referred to as the sisters. And the children who do not grow out of it were called persisters. And if they didn't have transition services, they would remain dysphoric throughout adolescence and adulthood. Now, this literature has come under attack by many people who are both in the trans community and supporters of the trans community that say that persistence is a myth because the studies use more overly inclusive diagnostic criteria from the DSM-3s and 4. But one of the major difficulties is that the research runs counter to a popular belief that people are born trans. And let's be very clear, we don't know why people are trans, we don't know why people are cisgender, we don't know why people are gay, and we don't know why people are heterosexual. So, but the more that people you're born that way, the more people are likely to be accepting of gay and trans people. So this is one of the problems of this kind of literature. So the treatment approaches to the kids vary depending on where you are. I became interested in this subject when I was working on DSM-5 because I'm not a child and an adolescent psychiatrist, and so I treat older adolescents, but not really young kids. So I became curious with my colleague Bill Bine, and we asked 7 clinics. 5 of them responded. If you could tell us what you do, so we can understand, what happens with these kids. And we got 5 reports, and we kind of try to synthesize what we think the research shows and what we don't know. So we believe that the children who present are a heterogeneous group, that not all of them are the same. And because despite the attention they get in the popular media, the number of kids with GD is low in the general population. But while still relatively small, the number presenting to gender clinics in recent years is increasing. And the increases, and actually since we wrote this, we did these chapters and edited this book, the numbers are increasing even more with the ratio. It used to be gender birth assigned boys outnumbered birth assigned girls, and now those numbers are reversing. The research shows that the majority do not persist, and they're called sisters. And prospective studies indicate that the majority of them grow up to be gay, not transgender, and a small proportion grow up to be heterosexual and cisgender, and that there is no way to predict in which child, we're talking about prepubescent children, will or will not persist into adolescence or beyond, and that if it persists into adolescence, it's more likely to persist into adulthood. And so the presentations and needs of prepubertal children differ from those of adolescents, requiring different clinical approaches for the two age groups. So we don't know what causes it. We have nobody knows. Anybody has a theory, good for them. They haven't proven it. We don't know how anybody's gender identity develops, whether we're cisgender or transgender. And we don't know the relative contributions of biology and psychosocial environmental factors in development of gender identity, whether cisgender or transgender. In recent years, I've actually done private consultations with parents who've reached out to me based on what they've read about my work on the internet, or they're referred to me by colleagues who know me. And I say to parents, the first thing I say to parents is, look, these kids appear in the homes of Democrats and Republicans. It's not related to parenting style, whether your child develops gender dysphoria. We don't know whether the stress comes from the gender dysphoria itself as opposed to non-acceptance, or whether there's even one answer to this question. And we don't know why some kids desist and some persist. We don't know. So in 2008, I recommended to the American Psychiatric Association, you know, we have treatment guidelines for many of our diagnoses, but since we have this diagnosis in our manual since 1980, we've never done any treatment approaches. So the APA put together a task force which published its results in 2012, chaired by my colleague Bill Vine and a number of people from a variety of different perspectives on how to treat these children. And they found, and there was no conflict when it came to their decision about what were recommended guidelines for older adolescents and for adults. But there was controversy in the approaches to treatment, and I'll just put them all up, for prepubescent children. The task force could not reach consensus. So the Canadian clinic worked CAMH. Their goal was to lessen the gender dysphoria, to try and decrease cross-gender behavior and identification to prevent the child from growing up to be transgender, basically, or transsexual. Whereas the Dutch clinic in Amsterdam, their approach was not to try and lessen the gender dysphoria or gender typical behaviors. They did something more like watchful waiting, in which their goal was, you know, let the child express themselves, unlike the Canadian clinic, which tried to, you know, like, if your child liked to play girls' games, your assigned boy liked to play girls' games, the trick was to get him to stop doing that. Try to get him more comfortable with other kids of all genders. The Dutch said, don't shame a child, you know, by making their gender atypical interests a matter of controversy, but let them be who they are. Let's wait and see, let it unfold. And which is what they call watchful waiting. The only thing they don't want to do is they don't want to socially transition the kids, because they don't know whether the kid is going to grow up to be trans or cis. So they didn't that. Whereas here, mostly in the US, we're seeing more of what's called the gender affirmative approach, where the assumption is that if the child presents as transgender, that they will grow up to be transgender. And if they change their mind, there's no harm, because the transition is only social. This is the approach that is, of course, generating enormous controversy around in many countries, as I'll talk about. And this is a comparison of the three approaches. So none of the, so if you starting on the far right, none of the Dutch and the gender affirmative approach do not try to prevent transsexualism, but the Toronto approach, they directly say that they did. None of them try to prevent the kids from growing up gay, if that's the outcome. All of them will do puberty suppression, which I'll just describe shortly, regardless of what they do for kids at a certain age. Social transition is discouraged by the Dutch and the Canadian clinic, and cross-gender interests in play are discouraged by the Toronto clinic. Now, puberty suppression, which was invented by the Dutch more than 20 years ago, is a time when kids who are gender dysphoric may develop panic attacks, may develop suicidal feelings, because they're either starting to change or they're worrying that the changes are going to have. So that it was a treatment that existed prior to this. There's a condition called precocious puberty, kids who develop puberty at age 9, which can cause a lot of social problems, if not to mention some physical problems for the child. So puberty blockers were used to suppress puberty until they reached an age of, say, like 12, which is a more common time for puberty. And the idea was for the transgender kids that they use this to prevent them from developing the what we call secondary sexual characteristics of their birth assigned gender, because One, it was causing psychological problems, and two, it also would cause, if they didn't desist, if they continued to be dysphoric after puberty, they would have less medical treatment needed. You wouldn't need to do mastectomies in birth-assigned girls. You wouldn't need to shave the Adam's apples or do electrolysis on a beer or have the growth spurts. And as I said, all the approaches would do this to try and give the kids more time. This is just how the puberty blockers not work, but it's the last part is the important part. It gives all these kids time out to explore options available. So if the child desists, let's say they start puberty blockers at 13, but at age 14, they say, I'm no longer, I don't think I'm, I think I'm my birth assigned gender. You can stop the puberty blockers and they have a later onset puberty without a problem. But if they don't, then, they don't develop those secondary sex characteristics. So research shows this period up to several years. The longest term studies are about 20 years. The social factors are going on around these issues. Now, right now, 20 states, Washington, D.C., and Ontario passed laws banning efforts to change a minor's sexual orientation or their gender identity, which is what accusations were made against the Canadian clinic because they did try to prevent transsexualism in adulthood. So shortly after the Ontario law passed, the complaints were filed against Ken Zucker, who is the head of the clinic, also the chair of the DSM-5 work group. And the clinic was closed and its longtime director dismissed. He took them to court and they apologized and gave him more than $500,000 US in damages, legal fees, and interest. But nevertheless, they were able to keep the clinic closed, which was a political problem for the Canadian national healthcare system. So back to the headline. I told you about the Dallas kids who 7-year-olds, one assigned boy wanted to transition. Mom said yes, dad said no, they're divorced, joint custody, they go to court. And so a Dallas jury, 11 people in the Dallas jury voted to support the mom's wish to socially transition the child. This was major headlines throughout the country, probably around the world as well. And there was an immediate political aftermath. The Texas governor promised to order the state's child protective services to investigate the case. One Texas legislator proposed a bill to define transitioning as a minor as child abuse. The judge, smelling the political air, vacated the jury decision, granting the parents joint custody, which is where they started to begin with. And then the judge was removed from the case because she had apparently posted a newspaper story about the case on her Facebook page. So a number of states have already have bills in the works starting around this time, trying to make it a crime for a doctor or any healthcare professional to treat a transgender child with any kind of medical or surgical treatment. These acts were introduced in 2019, 2020. They all, talk about criminalizing treatment. Arkansas this year, in March, the legislators actually did send the governor a bill banning medical care for transgender minors under 18. On April 5th, the governor vetoed the bill, and on April 6th, the day after, the legislature overrides the veto. This will probably be taken to court. In the UK, this is happening in other places around the world as well. In the UK, the Tavistock Clinic in London, some staffers publicly complained about the gender identity service there, and the National Health Service launched an independent review, which I think came out recently. I haven't read it yet, but I think was very critical. A lawsuit was filed against the clinic in January of last year because of the pandemic. They didn't hear the case until October. And the legal issues concerned identifying circumstances in which a child was competent as a matter of law to give valid consent to treatment. One of the two plaintiffs, what they call claimants in the UK system, was a mother of a 15-year-old child who was on their waiting list, who had concerns about her child's ability to give consent. And the more dramatic claimant and plaintiff was Cara Bell, who is a 23-year-old detransitioner, which is a term that's out there as well for people who transitioned in one direction and then transitioned back. She was given puberty blockers at age 16, masculinizing hormones at 17. At 20, she had a double mastectomy, but at 22, her gender dysphoria went away. So she stopped her hormones and identified as female. And one of the witnesses was a nurse who used to work there. Her husband just wrote a piece for the British Journal of Psychiatry, which from a psychoanalytic perspective, which is very critical and kind of scaremongering. I'm now writing a response to her husband, Marcus Evans. So the court decided, so what did the court decide just in December? That children below the age of 16 cannot be considered competent to give consent to treatment because they lack the capacity to understand the long-term adverse consequences of treatment with puberty blockers or hormones. In respect to young persons age 16 and over, the legal position is that there's a statutory presumption that they do have the ability to consent to medical treatment. So given the long-term consequences of clinical intervention issue, and that given treatment is yet innovative and experimental, which it's not, by the way, it's the 20 years is no longer innovative or experimental, the court recognized clinicians may well regard these as cases where authorization of the court should be sought before starting treatment with puberty blocking drugs. So let's be clear what this means. This means that judges who know nothing about these kids are going to be the ones who have to decide rather than the healthcare professionals, whether or not the child gets treatment. So there are some papers on treatment guidelines, which I'm happy to share. Also, the World Professional Association of Transgender Health, their standards of care are on the internet. You can download the PDF yourself. I've written some articles I'm happy to share with anybody who's interested. For those of you who are interested in LGBT mental health issues, I have a listserv to which I am the only one who posts, so there's no chatter. And there's anonymity and confidentiality. If you're interested, you can send me an email at jackdreschermd@gmail.com. And that's it.
Thank you, Dr. Drescher. There's a few questions. The first question was, there was a little bit of confusion about sexual identity, possibly maybe against, they just wrote confused about sexual identity.
Okay, well, it's possible, for example, to have a homosexual attraction and not identify as gay. There was a whole ex-gay movement in the United States that was subsidized by the religious right as a way to try and convince legislators that they shouldn't pass gay marriage because this person used to be gay and now they're not gay anymore. So therefore, being gay is not the same thing as being Black, or an ethnic identity, that because you can change it, and of course, there are many scandals of the ex-gay movement to prominent leaders of the movement who, after, years later said, well, I'm really gay. I never lost my sexual attractions. So you can have homosexual attractions, for example, but not identify as gay. You can become a Catholic priest, for example, because and choose not to act on those feelings. So you don't identify as gay, even though you have those feelings. So my identity, how I think about my feelings, is not the same thing as who I'm attracted to.
Thank you. Okay, the second question is, do you have any additional information, or can you direct us to additional information about eating disorders in this population?
In this population, no, I don't have any information on that. I'm not aware that it is a high prevalence. One of the correlations is autism. There is a correlation in the literature. We don't know whether there's a causation, but there is a correlation that there is a significant number of people who have both autism spectrum disorders and may also have gender dysphoria, but why that is, nobody knows.
Okay. Another question is, people are curious about the research about 16 years being the age of understanding consequences. Is there a little more info about that, or?
Well, I don't know the end. I mean, I think, I don't know how the judges in the UK came to their conclusion. Okay, I think it may have to do more with their own traditions. If you read the standards of care for groups like WPATH, first of all, I mean, it's interesting to me because I'm confused a little bit about what's going on, because I was always under the impression that any kid who's a minor needs parental consent to get any treatment at all. And that there are rare circumstances where people under a certain age are allowed to get treatment without parental consent. You would have to declare the child autonomous, or independent, from a parent who objected, for example. So the question I think really has to do with, whenever you're doing any kind of procedure on a child, although you may need parental consent, you want child consent too. And the question is, and so traditionally, you want the child involved in the decision-making process, even if they're under 16. I'm not talking about 3 or 4, but certainly 14, 15, you would want them to be part of the discussion about whether they're going to get any kind of medical intervention. So I'm not exactly sure how the judges came to their conclusion. So I don't know the answer to that question. So let me just point out, you're going to hear, whenever I give these talks, there's a lot of, I don't know. People don't like experts to say, I don't know, but there are a lot of things we don't know.
Okay. Another question was, what is your feeling about hormones? Do they cause psychological issues for kids, especially for those who have other issues like ADHD or OCD?
Well, I don't think so. I mean, first of all, usually nobody gets hormones until age 16. Okay, nobody gets surgery until age 18. This is a culture war issue. I'm digressing a little bit from the question because of my free associations help me come back to it. But, I get called, a Fox News journalist in Oregon, calls, this is through the American Psychiatric, I do calls for them. I have a 15-year-old, the law in Oregon now says that if there's a 15-year-old girl wants, gender surgery, she's allowed to have it even if the parents don't consent. So I had asked the reporter 2 questions. One question was, is there such a child? I mean, is there a case that you're working on? He goes, no. I said, have you met a surgeon who would perform surgery on a 15-year-old without parental consent? He goes, no, but it's the principle of the thing. So the principle of the thing is the hysteria that gets whipped up around, what should people have? So no, as far as I know, I don't think hormones interfere with attention deficit disorder or OCD. I think it's not unrelated to whether, the treatment of gender dysphoria. There are many conditions that present in psychiatrist's office, for example, where people have other medical conditions as well as, some psychiatric conditions, or may have more than one diagnosis. There's a balance to be found, but I'm unaware of any literature that says that hormones worsen those 2 conditions of attention deficit disorder or OCD. But if you want to find that, you can always go to PubMed, which is Medline on the internet, and that is the best place to search for the best peer-reviewed literature. Just type into the search engine, and that's a reliable source of peer-reviewed studies.
Thank you. One other question we have, I'll read it. In being an advocate for LGBTQ rights, the adolescent transitions create a tripwire. We advocate that sexual orientation is not a choice. Gender identity confuses us. And are you saying gender dysphoria might be a choice?
No, not at all. Gender dysphoria is not a choice. And that's really, the problem we have now, I'm working on a discussion, is you have at least 2 categories of children. You have children who will benefit from treatment and children who might regret the treatment. Okay, you have 2, let's say 2 broadly, I don't want to be binary, but broadly 2 basic categories of children. And what the British court is saying, and what in Republican states are saying is, we don't care what happens to the kids who will suffer if they don't get treatment, as long as we can save the kids who might be confused. That's where their priorities lie. And that, in my opinion, is an ethical problem, because, we should be worried about both groups of children. Okay. And the problem is that nobody is really paying attention to how can we help both groups by refining the ways in which we think about which child is which. This in part, I think, is a function of the loss of the so-called gatekeeping function, which is that I'm a psychoanalyst, which means that any person comes into me, usually wants to contemplate a major life decision. Well, let's talk about it. My goal in anybody's life, with any patient's life, if they're contemplating a major life decision that they might regret later on, is to help them look at the pluses and the minuses so that even if they do regret it later on, at least they made the best choice at the time when they made it because they did their due diligence. That, to me, is the way to approach things. What I'm getting complaints about, people are complaining to me. I have a longtime friend, her 17-year-old child is, announcing transition, is that, that they feel that the child walks into the therapist's office and after 2 sessions, the therapist says, okay, here's your letter for hormones. That there isn't a lot of time being given to deliberate. So I know it's not politically correct to talk about slow down, but I think you should always slow down if you're going to make a major decision. For some people, gender transition that will not solve all your problems. Actually, for most people, gender transition will not solve all your problems. And there are some people who are satisfied with, like, for example, I'm working with a patient who, for a number of years, transitioned as a trans man now, and had been contemplating bottom surgery, okay, and then changed their mind, okay. But I get it. I got a text yesterday. I'm sorry I changed my mind because, of course, the surgeon had a waiting list and it got postponed. So if they want to go back on the waiting list, it'll take a long time. And we didn't have a conversation because I'm trying to discourage deep conversations by text message. So I don't know, but I assume that he's in a very bad place. And that's why, because in the moment that he's in a bad place, he wants more treatment. Okay. And so that could happen, that if something else is making me upset, it could activate my gender dysphoria and make me hope that, more treatment will make me feel better. So that, is one possibility. But as I said, think of that elephant, think of all the moving parts, there's no one answer. So the really important part is what I think of as the individualization of treatment. That is, all the transgender people in my practice are all completely different from each other in their lives and their choices and what works for them, what doesn't work for them, because of the sensationalism around it. It tend to be put in therapists too. They put it in a box, and it's not always so simple. The mom that I talked to yesterday, who's a long-term friend, I was trying to sort of sort out what's going on. Look, the child is 17, it's going to be 18. This was a good child, a compliant child, a collaborative child, and now they're going through their adolescence. I said, they want to do this. I said, well, who's paying to see that therapist? Who's going to pay for the hormones? They live in your house without rent. I said, if you don't like it, you can always, become an authoritarian parent. And, well, I've always tried to be the parent who tries to reason. I said, well, that's not working right now. So maybe you need to talk to some of your friends. I don't have children myself, so I can't give expert child advice. I said, but talk to your friends who've had a problematic child. This is no different in some ways than any other kind of issue where the child and the parents don't agree, and you're forgetting everything you know about parenting. Just as some therapists forget everything they know about therapy when they meet a transgender patient.
Thank you so much, Dr. Drescher. It was really excellent to be able to hear you again from my perspective, and for giving us the resources for us to look up, and your very informative and thorough presentation for us. Thank you again.